Very good morning, ladies and gentlemen, and welcome to yet another CPT program to advance your knowledge on antimicrobial resistance. Just before going into our routine lecture, I would want to remember all of you about our housekeeping arrangements. So this webinar link will be available only up to 9:45 a.m. to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guideline. This is to improve and to maintain the standard of the CPD program conducted by Shri. Thank you for all of you to strictly adhering for these CPD regulations. So, on behalf of the Society for Health Research and Innovation, now I would like to invite Dr. Himal Abeywarnaarachchi, Acting Consultant Physician at Base Hospital Mahaoya, to introduce our distinguished speaker today. Over to you, sir.
Good morning, everyone. Thank you, Sahan, for your kind introduction and the housekeeping messages. Today we chose a very timely topic to discuss with you. Let me remind you first, this is a collaborative session with GMO Shri and Sri Lankan College of Internal Medicine with their generous support. Ladies and gentlemen, we chose this topic for you since we believe the antibiotic practice and the use in healthcare setting has not been very regularized in this country, and it is outdated. We have invited a resource person who has a vast major experience and knowledge in this field to discuss this topic with you. It's my great privilege to introduce today's speaker to you. She's Dr. Deepika, a consultant microbiologist in the Department of Microbiology in District General Hospital, Mathura. Dr. Abeywarnaarachchi, Deepika MBBS MD. She's a product of Ruhuna Medical Faculty. She gained her Doctor of Medicine in Medical Microbiology in PGIM, University of Colombo at 2009. And same time she achieved her postgraduate diploma in microbiology in PGIM, University of Colombo, and she got her overseas training in St. George's Hospital, London, in United Kingdom. She's board certified as a consultant microbiologist since January 2011. She has more than 10 years of experience in this field, and currently she's working as a consultant microbiology Department of Microbiology in District General Hospital, Mathura since 2019. She has contributed support and contribution for many guidelines and authorships on her expertise. Then she's a committee member of developing national antibiotic guideline for Sri Lanka from College of Microbiology in 2015. Currently, she is involved in many upcoming guideline development. We will be we are very happy to join with you, madam, regarding our topic. And without further ado, let me invite Dr. Deepika to start her talk. Let me remind you, we will be entertaining all your questions at the end of the session. Thank you. Madam, session is over to you.
Good morning, everybody. Thank you very much, Dr. Himal, for your kind introduction. And at the same time, thank you very much for organizing committee, giving this opportunity. My topic today is Go Blue for AMR to avoid returning to dark era. Actually, this is about antibiotic resistance and what can we do to overcome that problem. You will realize why I selected these words for my topic when I go on. First of all, I would like to take you all to pre-antibiotic era, the dark era. We all know that infection were the main problem for mortality at that time. Even with the scientific evidence we are having, by 1915, infection had been identified as a major cause of mortality for which something had to be done. Then accidental discovery of penicillin revolutionized our whole medicine. Since the introduction of antibiotics into medicine in the 1940s, antibiotics have been the backbone of modern medicine. Their role has expanded from treating serious infection to preventing infections in surgical patients, protecting cancer patients, and people with compromised immune systems, and promoting growth and preventing disease in livestock and other food animals. Actually, what happened since then, we have been using more than that, we have been misusing, overusing antibiotics. And now antibiotics are the most widely used as well as unwisely used therapeutic agent worldwide. That is the bitter truth of antibiotics. There are enough research evidence when we use more and more antibiotic resistance also more and more. Now let's talk a little bit about genetic elements of resistance. We all know that we know about two types of resistance. Number one, intrinsic or natural resistance, other one is acquired resistance. Actually, we are not worrying about any natural thing. We know that nature gives things in a very balanced way. Actually, we are really worrying about this acquired resistance. When we use antibiotic, what happens, we apply selective pressure. What we want bacteria to die. It happens, but at the same time, some of them get adapted. What happens after that? They survive and they carry genes for resistance to next generation. Bacteria are particularly efficient in enhancing the effect of resistance because of several reasons. Number one, their ability to multiply very rapidly. In general terms, every bacteria get double within 20-30 minutes. So you can imagine within 24 hours how many bacteria are there if we start from 1, 2, 4, 8, 16, so on. The other ability, they can transfer their resistant genes horizontally as well. Because of those reasons, they are particularly efficient in enhancing the effect of antibiotic resistance. Then our activities also contribute for that. We all know that we use antibiotic, we overuse, misuse not only in humans, then for animals, livestock, then environment, and this all things are interconnected. And now because of globalization or global village, it can spread each and every country. Actually, it happens, the speed is more than what we anticipate, what we think. I just want to remember you that great man, Sir Alexander Fleming, who invented penicillin. At the acceptance speech of his Nobel Prize, he warned that overuse of penicillin might lead to bacterial resistance. That is also a very good incident. The person who invented at the same time warned us not to misuse, not to overuse this. But we didn't take that much of care about that. So what has really happened, we know that we started using antibiotics in 1940, still 80 years, not has completed even 100 years, that is 20. So what happened when we use antibiotic more and more, increase in resistant strains, then ineffective empiric therapy, then we have to increase more antibiotics and increase morbidity as well, then increase hospitalization, increase healthcare resource use, then again more antibiotics, again increase mortality. This will go on and on. Actually, this is not antibiotic resistant cycle, more than that antibiotic resistant vicious cycle. Now we have come to a state that antibiotic resistance is one of the top 10 global public health threats facing humanity. Our time with antimicrobial is running out. The other problem that is, we all know that one health challenge, that antibiotic resistant problem is not only for humans, that animals and environment also. So it's a one health challenge. If I talk in simple way of consequences of antibiotic resistance, fail to respond first line treatment result in prolonged illness, greater risk of death and longer period of infectivity. Then we have to use second line drugs. What are the problems with these drugs? They are more expensive, more toxic, less effective, as well as not freely available. Then it is very costly. To whom? To patient as well as to hospital. Then what happens in the absence of, when patient is longer period in the hospital, he can't go for work and so many things. It affects the society also. I think you all agree with me if I tell that this is a socio-economic burden. Not only that, another important point during treatment, not only the infecting microbe, but also the patient and all his or her normal microbial flora are being exposed to the effect of the antibacterial agents. That is also a huge problem. Commensals are there actually to help us. What happens when we use antibiotics? That affect for them as well. Then getting an antibiotic increases a patient's chance of becoming colonized or infected with a resistant organism. That commensal organism doing a security job for us. All the openings where internal environment exposed to the external environment, they are there and they are doing a good job for us. They are not allowing pathogens to come and settle. That is because they compete for food and lodging. When they are not there, commensals are not there, what happens? It's more facilitating pathogenic organisms come and colonize. Then the other important thing, symbiosis of gut bacteria. 90% of our commensal flora lodge in gut. So what they do for us? Food digestion, nutrient production, nutrient absorption, immunity development, hormonal homeostasis, and development of higher functions of brain. That is microbiota gut-brain axis. So we lose everything when we use antibiotics in addition to developing antibiotic resistance. Not only that, we know that with the invention of antibiotics, we made big changes in our medicine. Now we are doing various miracles, that organ transplantation, prosthesis insertion, then cancer patients, they survive more and more. But because of this resistance, it challenge for each and every miracles in medicine. That sepsis treatment, then chronic conditions, then organ transplants, then dialysis, cancer care, they all will go back again to that like in pre-antibiotic era, dark era, because of no antibiotics to give. Everything has become resistant now. This is the forecast of death in 2050. You can see that huge problem in our own continent, Asian continent. And at the same time, They predict that antimicrobial resistant death will be around 10 million in 2050. Actually, it is more than cancer deaths. Can you imagine the gravity of the problem? What happened in the past? The problem of resistance to antimicrobial was addressed by developing new agents to which clinically important pathogens were not, at least initially, resistant. What we call antibiotic resistance was tackled by super drugs for super bugs. We invented penicillin and we started treating infections with penicillin, but within few years, microorganisms invented penicillinase to destroy our antibiotics. So we couldn't use penicillin anymore to staph infections. Then we invented cloxacillin. What happened again? After a few years of usage, they produce a way to destroy this as well. Then we started using vancomycin for MRSA, cloxacillin resistant category we call MRSA, and then we invented vancomycin. We came up to recent 20 years or so this way, but anymore we can't practice that method. That is because lack of new antibiotics to use in near future. Our pipeline is dry. This slide is quite busy, but I wanted to put everything together to emphasize the gravity of the problem. You can see that decline antimicrobial approval, and at the same time, the other side, antimicrobial resistance is going up, up, up. Actually, this is a double trouble. If neglected, it has profound impact on health and economy of the country. This is bad, sad, and pathetic situation. If we neglect, what will happen? Actually, young generations, children, but in my age, people's grandchildren, they will die again with infection like in pre-antibiotic era. That will happen. So, are we going to wait it to happen, or what we should do? We should try our level best to control this. Let's talk how to overcome the problem. World Health Organization at the 68th World Health Assembly in 2015 endorsed a global action plan to tackle antimicrobial resistance. There are 5 main strategies for that, and number 1 is increase in national awareness of antimicrobial resistance, improve knowledge of antimicrobial resistance and related topics. WOW came that way. WOW, that is World Antimicrobial Awareness Week. We do various things for that since 2015. Every year from 18th to 24th November, that week, that is WOW week. Very recently, we just passed that period, and I am happy to address just after that WOW week to you all, just to remind certain important messages with related to antimicrobial resistance. Our color is all AMR activity color is blue. Now you can understand why my topic go blue to go blue for AMR to prevent antimicrobial resistance. That is that. So 2020 theme is preventing antimicrobial resistance together. Prudent use of available antibiotics are very important to tackle the problem. How to do that? Antibiotic resistance is a global problem, and antibiotic stewardship programs are the global solution. What is antibiotic stewardship? IDSA, it has very comprehensive explanation, definition for that. I'm not going to talk any one of those things at this moment, but at its core, antibiotic stewardship is a multifaceted, multidisciplinary, systematic approach to antibiotic optimization. In its simplest form, it's about saving what antibiotic we have. තියෙන antibiotic ටික පරෙස්සමට පාවිච්චි කරන්නේ කොහොමද කියලා. So, core elements of antibiotic stewardships. There are several elements, but I want to highlight the fact here: prescribing antibiotics when they are truly needed. That is number one. Then number two, prescribing appropriate antibiotics with adequate dosage. Then using the shortest duration of antibiotics based on evidence. Then reassessing treatment when culture results are available. Supporting surveillance of AMR and HAIs and monitoring of antibiotic consumption. Those are the very important points relevant to this crowd when we talk about core elements of antibiotic stewardship or antimicrobial stewardship. What are the goals? Obviously, we should improve the clinical outcome. But at the same time, it should be in our back of mind that combat the emergence of resistance and control the cost as well. What are the approaches to control AMR? Decrease selection pressure of antibiotics. That is rational use of antibiotic, then reduce transmission of AMR, infection prevention and control. Let's talk about rational use of antibiotic. We should have behavior change in antibiotic prescribing. I'm happy to discuss it under three subheadings: persuasive interventions, restrictive interventions, and structural interventions. First, we talk about persuasive intervention. That is basically education, knowledge, make aware the people, distribution of educational material, educating meetings, educational outreach visits, then reminders provided verbally on paper or on computer. Educating prescribers, it's very important. For what? Regarding what? That is rational use of antibiotics. The right antibiotic for the right patient at the right time with the right dose and the right route, causing the least harm to the patient and future patients. Another important message I want to highlight here: all the other drugs that affect only for that particular patient to whom we use that. But antibiotic story is different. We use for one patient, but it will affect for other patients and future generation as well. When we use antibiotics, what happens? Organisms, microorganisms, what we call at the moment we are talking about bacteria, but there are fungus, there are virus and other things as well. Then bacteria develop their resistance, and I explained at the beginning, once they get that ability, it spread rapidly. So it's very important message. Not like other drugs, antibiotic, when we use for one patient, it will affect for all the others as well as for the future generation. Then the other message, mind me, M microbiology guide therapy whenever possible. Indication should be evidence-based, then narrowest spectrum, then dosage appropriate to the site and the type of infection, then minimize the duration, ensure monotherapy wherever, whenever possible. Those are the basic things. We will go in details. Having said the importance of monotherapy and rational use of antibiotic, you can see here, this is actual drug chart. Don't misunderstand. This is not from Mathura, as I am from Mathura. Don't think this is from Mathura. That is not the case, but this is Sri Lankan, one of the Sri Lankan hospitals drug chart. See, teicoplanin, meropenem, levofloxacin, cefoperazone sulbactam, C-penicillin, doxycycline, and metronidazole. See the way utterly and miserably misusing antibiotic in our setups. So, misusing of antibiotics puts us all at risk. No two words about that. I just show the drug chart of our own hospital. Own hospital means Sri Lankan hospital, not Mathura. So, coming back again to educating prescribers, we have identified certain areas where we misuse antibiotics, given when they are not needed, then continued when they are no longer necessary. Then wrong antibiotic is given to treat an infection. Then broad spectrum agents are used to treat very susceptible bacteria. We'll see one by one. Given when they are not needed, very common instance is viral infection. We know that most of our respiratory infection, especially upper respiratory infections, as well as sometimes lower, most of the time they are viral. And acute gastroenteritis also same. Most of the time they are viral. You just imagine how much we are using for these conditions. Then the other thing is chronic wound. That is also another example where we misuse antibiotic, given when they are not indicated. Then continued when they are no longer necessary. Chronic wound again come into the picture. I have seen one patient was on antibiotics for 59 days for a chronic wound. Can you think when did they stop antibiotic? Patient died. Patient died due to some other reason, but VHT, we noticed that patient was on antibiotics, oral antibiotics for 59 days, 2 months for the chronic wound. I will explain when to give antibiotic for chronic wounds. Then drains. People think that when various drains are in situ, we should continue antibiotic until we take off the drain. No, that is not the case. The other place where we misuse prophylaxis. We are so keen to initiate antibiotics, but we are not then keen to stop antibiotic or review antibiotic. Then the third one, the wrong antibiotic is given to treat an infection. Very common thing again, ciprofloxacin for chest infection. Ciprofloxacin is not a respiratory quinolone. We all know that. But you ask yourself, how many times did you prescribe ciprofloxacin for chest infection? Then, knowing that Pseudomonas, infection is Pseudomonas, giving coamoxiclav. That is not in the panel even. So, then coming to the broad spectrum agents are used to treat very susceptible bacteria. I have seen so many instances. Given the report that very narrow spectrum antibiotics are sensitive, still continuing same meropenem and vancomycin. We know that septic patient, when you come across a septic patient, we don't know it is due to viral or bacterial, and as patient is in sepsis, you have to start a broad spectrum antibiotic at that point. But before starting antibiotic, it is very important to collect all the cultures. I was talking about broad spectrum agents are used to treat very susceptible bacteria. I will repeat what I said earlier. On admission, patient is in septic shock, you have to start broad spectrum antibiotic because you don't know the focus. Then you have to cover gram negative, gram positive, both. So you can start your meropenem and vancomycin both at that point. But please collect cultures before starting antibiotics whenever possible. So with the cultures, we inform when we isolate something. Imagine we isolate gram negative bacilli, then we inform this patient's blood culture is growing a gram negative bacilli. What we want you all to do to omit your vancomycin. Why? It doesn't have any cover for gram negatives. That has only gram positive cover. So following the morning, again, either we issue the report or we inform you all that particular gram negative bacilli is coliform or whatever that Klebsiella or E. coli, and which is sensitive to cefotaxime, ceftriaxone, cefuroxime, so on. That means narrow spectrum antibiotic when compared to meropenem. Then whole idea behind that to de-escalate the therapy to whatever that narrow spectrum antibiotic. But sometimes what people do, that patient responded to that particular combination, they want to continue the same. That is very irrational. What's the point? Then everybody will be on meropenem and vancomycin. That is very, very irrational. That is one example. Then the next thing, people use linezolid, levofloxacin, moxifloxacin, ciprofloxacin, azithromycin. They are very good drug, very broad spectrum, as well as our last resort antibiotic. But I have seen, I think you all are having more experience than me, being clinical people, that even for very minute things, mild cellulitis, that lower UTI, people use these drugs. Please don't do that. That is very, very irrational and promoting antibiotic resistance more and more. So, if we talk about possible reasons of misusing, lack of awareness, even prescribers sometimes, we know that we have to update. Continuous updating is very important. All prescribers, I think this program also that you all are conducting to update people, that continuous medical education, that is very good thing. Then lack of awareness of public also, it matters. They are the one who come and insist doctors to prescribe antibiotic. So awareness, lack of awareness of public also, it matters. Then poor compliance of patients. Sometimes doctor doesn't want to prescribe antibiotic, but doctor wants to get that patient to back to the clinic, but they won't come. Poor compliance. Then not doing basic investigations and microbiological investigation. What I mean by that, when patient come and complain fever and cough, some respiratory tract infection symptoms, sometimes you can't come to a conclusion whether it is bacterial or viral. Then people tend to be in safe side, they prescribe antibiotics. We all know that initial state that is viral, but later on bacterial superadded infection can occur. But don't prescribe antibiotics thinking secondary superadded bacterial infections. That is also, again, I want to highlight, by doing that you are causing harm more than the benefit. When you prescribe antibiotic, as I mentioned earlier, your commensal flora, either they die or get resistant. So by the time actually patient, you want to treat patient with antibiotic, that resistant flora get colonized. So thinking of that secondary bacterial infection in the future, don't prescribe antibiotics. Then I understand that unavailability of basic investigations and microbiological investigation also matters. Then pressure of companies also. They promote certain antibiotics, especially oral antibiotics. But that is also leading misuse of antibiotics. The other important thing, we are in a culture of to be in safe side, considering each and everything that patients poor compliance, then lack of awareness of public, unavailability of basic investigations. They are available, but again at costly, and thinking everything people, prescribers, what I mean, tend to prescribe antibiotics to be in safe side. There is a published study done by these names. It was found that tertiary care hospital, Sri Lankan study was done in Sri Lankan tertiary care hospital. Patient demand was cited as an important cause of antibiotic overuse. Some patients, they insist, they say that I have this thing, that thing, tomorrow exam, day after tomorrow some interview or something like that. Can you please prescribe antibiotic for me to get cure instantly? One shot, they are the one who promoting one shot doctors. But it's our duty, the doctor's duty, to explain them the real picture, as well as it's very important not to prescribe antibiotic on request. The physician indicated that high patient volume and fear of bacterial superinfection were causes for overuse. Then I have actually discussed the where we misuse antibiotic. Coming back to rational use of antibiotic, what we should do, we should carefully assess the need. It's very important get the evidence of bacterial infection from basic investigations such as full blood count and CRP. At the end, if we decide to prescribe antibiotic, again, try to take samples for culture and ABST. Then you should select best guess therapy. We know that what are the microorganisms, common organisms can cause respiratory tract infections. Then what are the microorganisms can cause UTI. Then select narrowest possible antibiotics. It's very important to prescribe adequate dose for the shortest possible duration. The another important thing, review the culture results and streamline the therapy, whatever you started at the beginning. Then the problem arise, what are the antibiotics we should use for UTI? What are the antibiotics, available antibiotics we should use for respiratory tract infection? So prescribers should follow national antibiotic guideline for that. This is the empirical and prophylactic use of antimicrobial national guideline prepared by our college with the collaboration of all the other professional colleges. At the moment, these days, we are doing that revision of this our guideline, national guideline. At the same time, we have decided to, it's a kind of flashcards for OPD and other GP practices. They can use in the OPD as well as GP practices. So what are the things you all can use at that level? Let's talk about common infections we encounter in OPD and GP level. You all agree with me, respiratory tract infections are one of the main infections you see day-to-day practice. Again, I want to highlight the fact majority of respiratory tract infections initially viral. Don't prescribe antibiotic prophylactically thinking of there will be a secondary bacteria. I have already discuss that. Then if you suspect secondary bacterial infection, clinically or with the evidence of basic investigations such as CRP and full blood count, what are the antibiotics you can use for the mild infection? Otherwise, you should advise patient to go and admit. But what I mean that patients who can be managed in OPD or GP level, amoxicillin, cefuroxime, and doxycycline you can use for those infections. If patient has had antibiotics in the prior month, you can think about bit of broad spectrum compared to previous one. Example, coamoxiclav. Then you think this is atypical, you can use clarithromycin. Please don't use ciprofloxacin. Again, I want to highlight the fact this is not respiratory quinolone. The other thing I am highlighting the importance of ciprofloxacin here, that is the only available oral option for Pseudomonas infection. When we want to switch to oral, that is the only available oral option for Pseudomonas. So don't misuse this ciprofloxacin for unnecessary things. Actually, no use of also. People think people get better with antibiotic, but that is not the case. All the viral infections, they get better anyway without anything within 3-4 days. That is rest and other things. Supportive care we should give, but not antibiotic. Better avoid azithromycin also. I know that clarithromycin, azithromycin, both are in the same category. That is category, those are macrolides. But clarithromycin is the drug you should use. Azithromycin, again, please preserve, that is more broad spectrum antibiotic. Again, when we use potent, that broad spectrum IV antibiotic, when we want to switch it to oral, we can use azithromycin if you not misuse that. In other countries, actually, azithromycin is the drug of choice for typhoid fever. So, better avoid that as well. Then, chronic wound. I told you I'm coming back to chronic wound again. Antibiotic not indicated if there is no evidence of either systemic or local infection. We all know that wound become chronic wound because of some predisposing factors. So, it is better to correct predisposing factors. Don't think that when wound is there, we should give antibiotics. Then rotational antiseptics also recommended, but I'm not the best person to talk about, that is surgical team. But all I can say, don't use local antibiotic creams. Instead of that, better to use rotational antiseptics. If there is evidence of infection, again, I want to highlight one fact. Pus is the best sample, then tissue and swab is the least preferable sample. That is, again, when you swab the wound, like over the skin, any organism, any microorganism can be over the chronic wound also. When you swab it, actually come in that colonized flora, but not the real organism causing infection. How do you overcome that? Preferably pus, then tissue, then soap. But imagine ultimately you have to collect the soap. What you should instruct the patient? You should tell them to go and have a bath or a wash or whatever, that cleaning process. After that, you should irrigate the wound with sterile normal saline. Then what is the idea behind that? To chase out all the colonizers. Then you rub the living tissue and send the sample. Just rub the living tissue. Then only it will become a good sample. Then finally you decided to give antibiotic. Then what should you cover? You cover the primary pathogens of wound infection. Those are staph and strep, staphylococcus and streptococcus. So what are the antibiotics? That is cloxacillin, flucloxacillin or cefalexin. Narrow spectrum antibiotic you can use for mild cellulitis and all. If it is a recurrent problem, frequent hospital stay, then you are thinking about MRSA risk and all, you can go for something like doxycycline, clindamycin or cotrimoxazole. I think you all agree with me. I can't put everything together in one basket. There are things, exceptional things. Then you can deviate, but norm, what I am talking, a norm scenario. So, if patient is having diabetic and you are not happy with the wound color and pain and everything, then you can go for a bit of broader cover. Example is coamoxiclav. Then UTI, the other common presentation to GP practice as well as OPD. Again, I want to tell the dysuria, just dysuria alone, you can't think that this is UTI. That may be due to concentrated urine. So you need some other factors. Clinical, you can ask about that fever, frequency, this thing, that thing, as well as the basic investigation and UFR. Whenever possible, if you suspect UTI, better to collect urine culture. Then other important thing, asymptomatic bacteriuria, that entity, no need antibiotic except pregnancy. Asymptomatic bacteriuria, no need antibiotic except pregnancy. Then excluding everything, you are coming to lower UTI. You want to treat this patient, you suspect lower UTI. So better to start urinary antiseptics for lower UTI. Things like nitrofurantoin and norfloxacin and cefalexin. I know that there are problems with nitrofurantoin. You have to take it 6 hourly, and there is a tendency of nauseation and vomiting. So patients' comply is poor, and prescribers also try to avoid nitrofurantoin. But I can say, when we analyze our ABSD pattern, more than 95% of our isolates are sensitive to nitrofurantoin. Why is that? We are not using nitrofurantoin that much. I understand the practical problems, but we have to explain the patient the problem, reassure them and give with antiemetic. That is the solution. Thinking of we can't give this because of 6 hourly and the tendency of vomiting, and so better avoid and go for Norflox. So Norflox, of course, all right, that augmentin or cefuroxime or something I have seen, and many times that I think you also aware about that people prescribe ciprofloxacin for lower UTI. Don't do that. I'm telling again and again, don't misuse Cipro. One thing is noise there, the other thing is Cipro, again, not for lower UTI. You can use nitrofurantoin, Norflox or cefalexin for lower UTI. Please explain the patient, and they will understand the situation and they will agree to have this very susceptible, that nitrofurantoin. Again, I want to highlight that 95% of our urinary isolates are sensitive to nitrofurantoin. Gastroenteritis, the other common presentation to OPD and GP level. Antibiotics are not usually recommended. Again, norm and exceptions may be there, but in general terms, antibiotics are not recommended for acute gastroenteritis. Assess the severity and dehydration and manage with oral rehydration therapy and probiotics. Don't prescribe antibiotics. So I have just completed the prescriber awareness. Now I want to talk a little bit about educating public as well, because they are the one who insist doctors to prescribe antibiotics. So educating public also very, very, very important. What are the messages? Cold, flu, get well without antibiotics. Then help your antibiotics do their jobs. When you prescribe antibiotics, it's very important to tell the patient then that this is the antibiotics and these are not antibiotics. And when you take antibiotics, take it in correct way, adequate dose, and as well as tell them 500 TDS means 500 TDS, not 500 BDO, 250 BDO. They can't enjoy antibiotics that way. You have to educate them how to take antibiotics. Again, messages for the public. Actually, we should educate the public, not for anything else. There should be a day people should come and tell prescribers not to prescribe antibiotic for us unless really indicated. What I mean by that, our general public should be knowledgeable up to that level. Then persuasive interventions I have discussed, then restrictive interventions. That is basically our authorization level. Actually, I'm not going to talk about in depth these topics, but formulary restriction also, it's important a step in antibiotic stewardship programs, pre-authorization, authorization for continued use. Like that, we should do some kind of restriction for our antibiotic. For example, house officer level prescription, these antibiotics, then SHO level, registrar level, and senior registrar level, consultant level, and MDT level, including microbiologist. We should have that levels. Otherwise, everybody will use meropenem, everybody will use vancomycin for unnecessary infections. Red light antibiotic came that way, but we should have orange and green light antibiotic as well. Then structural intervention also very important, the changing from paper to computerized records. I don't know when will that they come, but we should go for those things as well. Then it is very easy for clinicians, the laboratory people, they can enter the results and they can, clinicians can see the results from their end. Then rapid laboratory testing. I understand your difficulties also, that culture, it will take 3 days. So in our setup, certain other investigation, even CRP, full blood count, though I tell that better to get it done. I understand the practical problems as well, but nothing is easy in this world. So we should try to, I understand the problems, barriers, but we should try to get it done. Then I told that one main thing is rational use of antibiotic. The other thing is how to prevent spread of antimicrobial resistance, that is good hospital hygiene and infection control practices. I'm not going to talk about that at this moment. I'm coming to the end. Antibiotic versus resistant bacteria. It's a big match. So we should take 6 actions to win the match. We'll see one by one. Reduce the need for antibiotic through improved water, sanitation, and immunization. If there is no infections, no bacterial infections, definitely we can save our antibiotics. So it is very important step, that immunization. We know that by that we can reduce our infections. Then water, food, safe food and safe water, those things also very important. Then improve infection, hospital infection control, and antibiotic stewardship. Then change the incentives that encourage antibiotic overuse and misuse. to incentives that encourage antibiotic stewardship. Currently, what happened, everybody encouraged by giving incentives to use antibiotics. Now we should change our culture to incentives that encourage antibiotic stewardship. We should give incentives those who are not using or minimal using of antibiotic. Then reduce and eventually phase out subtherapeutic antibiotic use in agriculture, livestock, and I told you that we are not the only category using antibiotic. Then educate health professionals, policymakers, and the public, and sustainable antibiotic use also very important. Last but not least, ensure political commitment to meet the threat of antibiotic resistance. 6 actions. We should do all these things together to combat this problem. This is real teamwork. T together, E everyone, A achieve, M more. Together, everyone achieve more. We should all get together to combat this problem. This is another message. We all have a role to play. Everyone has a role to play. This is actually real teamwork. Again, I want to highlight. I'm going to end my presentation reminding again another important Mother Nature theory, that is low-hanging fruits. The expression of low-hanging fruits comes from a Mother Nature analogy and refers to the fruit that grows on lower branches and is usually more abundant and easier to pick. How it comes to our antibiotic stewardship program, when we select strategies, we should try to select strategies for which we can use less effort and less investment. Here I have selected few low-hanging fruits with regard to antimicrobial stewardship program. Education. We can do that. At the moment, I am doing that, and organizing committee organize this event also to educate the people. Then formulary restriction. We all, our hospital staff, can get together and we can make that formulary restriction. This is this level, that level, so on. Then IV to oral switch. For most of the conditions, we can make early IV to oral switch. We know that meningitis, septic arthritis, osteomyelitis, endocarditis, there are few conditions we have to continue IV antibiotics for longer duration, but most of other cases we can try this IV to oral switch. Again, another low-hanging fruits with regard to antimicrobial stewardship. Then this is our duty, issue a microbiology report with comment. We do that. We isolate Pseudomonas from a patient's sputum. Then we comment, please correlate clinically. This is probable colonizer. Chronic wounds, most of the time I do that. Pseudomonas is not a common organism causing wound infection. So this is probable colonizer. That means clinicians, we facilitate clinicians to take decision. Then it's very important antibiotic stewardship round. We all get together and do this. The other important message, when we do these things, we should see the good side. Most of the time, people used to see the empty side. Then what happened? We think we can't do that. Don't do things that way and don't see it that way. See the good side, half full, same scenario, but the way we see it. Try to see the half full, not to see the half empty. Otherwise, each and everything we think that we can't do. No, we can do. We can do many things. Again, that low-hanging fruit theory, if we see the good side and if we pick that less effort and easy strategies, we can complete our work more than half. That is for sure. So in our Sri Lankan setups, we can't do everything within 24 hours overnight. But most important thing, we should go with the forward gears. Slowly, it doesn't matter. Don't put reverse gears. We should go ahead with only with forward gears. So, coming to the end, thank you very much again for organizing committee for giving this opportunity, and big thank for you all audience for your careful listening and participation. Thank you so much.
Thank you, madam. Thank you for that fascinating talk about antibiotic and antibiotic resistance and rational use in clinical setting. Without further ado, let me take you to the Q&A. So the first question we have chose for you to discuss use of antibiotics in viral infection, suspecting secondary bacterial infections. What are the place for the use of antibiotics in viral infections, suspecting secondary bacterial infections?
What kind of viral infection? Is it respiratory? Is that respiratory?
Yeah, I think
infection?
The audience is asking respiratory.
Yes.
So
upper respiratory tract, actually, if it is pharyngitis, penicillin is the drug of choice. Still, group A is universally sensitive to penicillin. The bacterial pharyngitis, number one bacterial organism is group A streptococcus. So it is universally sensitive to penicillin. Then oral penicillin is the drug of choice. Then penicillin allergy or some other problem, erythromycin we can use. Then amoxicillin also we can, but better avoid amoxicillin, so clavulanic convert, augmentin, better avoid.
The next question is, any local study which was found about definitive antimicrobial resistance in Sri Lanka?
Say it again, Himal.
Can I repeat?
Yeah, yes, please.
Any local studies you have found?
Yes.
Any local studies you have found about definitive antimicrobial resistance in Sri Lanka?
Yes, the thing is this, our colleague, we are doing glass study. For that, we are collecting data all over the Sri Lanka, but we are having many problems because that standard of our microbiology laboratory not up to the mark. So people are doing various, what I mean that we are doing CLSI, the other people doing Jones stroke. So before that, we want to universally, we can analyze data if we use, if we practice the same way to do this. We are having issues regarding that, but we have certain data which has been done in local hospitals. According to those data, our MRSA rate is more than 50%. Our ESBL rate is more than 30%. Actually, it's in between 30 to 45. As a colleague, we have been working hard to collect data from at least representing all the provinces and make a report. We are having data, but again, I have to tell, we can't homogenize to say that this is the Sri Lankan. For that, we have to collect data from all provinces. We have been working hard to do that. But for that question, what I can say, we analyze generally every 3 months, every 6 months in our local data, our hospital data. According to that, we are also having very high rates of antimicrobial resistance. I don't know whether I answered the question.
Yes, madam. Is there a discrepancy from the developed country, that means UK or United Kingdom or Australia from Sri Lanka regarding the resistance? You said
yes.
35%.
Yes. Developing countries' resistance rates are very high compared to developed countries. That is because not anything else, they are having very restricted use of antibiotics. We misuse, we overuse. That's why our rates are very high. That is obvious.
Of course. What are the most common antibiotics that has developed the resistance?
What are the antibiotics more we use more and more? Answer is that. So ampicillin for the E. coli, actually that question is quite answering that question is bit difficult. For ampicillin, our coliform almost all resistant to ampicillin. What I'm talking about our hospital data, but that is the impression of other microbiologists as well. Then cephaloxime, cefuroxime, those things also for E. coli. Actually, when we talk about resistance, we have to tell that the organism and the resistant. I recommend that cephaloxime for upper respiratory tract infection, so that organisms, not E. coli. So it's answering to that question. I have to make a list for this particular organism. This is the most resistant antibiotic and so on. But antibiotic resistant in generally, there are instances, there are isolate. We can't give anything 100% resistant, even for meropenem, even for imipenem, even for cephalosporin sulbactam.
Yes. What is the next question is, what is the antibiotic of choice for cellulitis, and can we use the penicillin as a first line drug? Let me repeat it. What is the antibiotic of choice for cellulitis, and can we use penicillin as a first choice?
I should say yes, but at the same time, I have to add certain things that streptococcus and the staphylococcus both causing cellulitis. For the streptococcus group A streptococci, yes, that is the drug of choice. But when we don't have a report, we think this patient is having cellulitis. In that case, we have to combine it with staph cover antibiotic as well. If the organism, we have isolated the organism and that is so group A, drug of choice is penicillin, no two words. But without knowing that, I think what I can recommend, better to cover step and strep both if you don't know the organism. Then penicillin with...
Madam, in that case, we use penicillin. The case we use penicillin, what is the best combination you recommend? Penicillin with?
Clindamycin, penicillin and clindamycin. Again, that just mild, very mild cellulitis. We can use cephaloxime as a single drug to cover the staph and strep both. And even flucloxacillin, we can try because it has strep cover as well. But if we give penicillin alone without knowing the etiological agent, there is a risk. So if we can give fluclox, that is safe. If you know the bug, that is group A, definitely penicillin. And I want to just tell that flucloxacillin and cloxacillin also, flucloxacillin basically coverage is same, but absorption and penetration and those things, flucloxacillin is better than cloxacillin, but there is a big difference in the price also. Flucloxacillin is very expensive.
The next question is, what is the antibiotic of choice for recurrent urinary tract infections?
Good question. Recurrent urinary tract infection, first we look why it is recurrent. Why recurrence is there? That is number one. We should look into that. There should be underlying reason to get recurrent UTI. So in those cases, what I recommend, take culture and ABSD, take samples for culture and ABSD before starting antibiotic. That is number one. Number two, in these cases, that is not simple or lower urinary tract infection. In that case, we have to go for higher one, either amoxicillin, clavulanic, something like that actually. Then definitely we have to review with the culture and ABST report. It's very important to look into what is the reason for the recurrence attacks.
The next question is duration of broad spectrum antibiotics in the expense of resistance. Duration of broad spectrum antibiotic in the expense of resistance. How long we have to continue if we start broad spectrum antibiotics?
Again, the question for what? That depend on the clinical condition. If it is cellulitis, the duration is it's like 2 weeks. But if it is that respiratory tract infection, it is 5 to 7 days. That depend on the clinical response, as well as we have to monitor the patient with the inflammatory markers and all. Broad spectrum antibiotic, the story behind that, we can start broad spectrum antibiotics when we don't know the focus, we have to. But we have to review with the culture results and de-escalate or streamline the therapy. Exact duration depend on the clinical condition.
What is the place for IV antibiotics in the cases of clean surgery? Let me repeat it again. What is the
clean
place for
surgery?
IV
I got it.
in the case of yes.
That is only for prophylaxis. For the clean surgeries, again, broad question. Even for, so there are certain clean surgeries, we don't recommend antibiotic prophylaxis. But that let's say that heart surgery and so on, for that we recommend prophylactic antibiotic. That is only for prophylaxis. But so herniatomy, those things actually we don't recommend. But again, I want to add 1 or 2 sentences. Most of those guidelines, they recommend just 1 dose of antibiotics. In our setup, we allow up to 3 doses because of our setups and things not up to that level, but not beyond that. Everything depends on the condition and the other factors as well. That hard and fast blanket cover, I can't say that this is only 2 days, 2-3 days. Most of the conditions we have to consider with the what is the clinical condition. Antibiotic duration depend on many things, no?
Yes. The next question is, what is the antibiotic of choice for chronic pseudomonas infection? The wound, chronic wound with chronic pseudomonas infection.
No antibiotics. Chronic wound, pseudomonas, they are colonizers. No antibiotics. Only rotational antiseptics.
The last question, madam. What are the occasions we use the IV and oral metronidazole? So I think this question, the audience, the person who asked this question, we have seen a lot of regimen in a hospital when in outpatient practice, people are using, doctors are using metronidazole. So what are the ideal indications we use metronidazole with the antibiotic?
Yes, good question. Actually, I would have addressed that metronidazole I should have mentioned in my presentation. Good that somebody asked that question. That is, metronidazole, our aim to cover anaerobe. But don't forget, antibiotics we use, examples, meropenem, coamoxiclav, clindamycin, those antibiotics also, they have very good cover, anaerobic cover. But metronidazole, very specifically, we recommend for abdominal sepsis, where gut flora came out. If we think gut flora has come out, so we have to give metronidazole because that Bacteroides fragilis and there are few anaerobes not covered by others. So for the abdominal sepsis, yes, that is indicated, but most of other situations, when we give coamoxiclav, when we give clindamycin, when we give piperacillin tazobactam, when we give meropenem, metronidazole is not indicated. Did I answer the question, Himal?
Yes, madam. Yes. Madam, it's very important to if we can go through the questions we have given to the audience. Shall I share my screen to see that questions?
Yes, please.
Right. So let me read the question to you. A 45-year-old previously healthy woman presented to a general practitioner with a dysuria and increased urinary frequency for 2 days. Her urine report shows 30 to 40 parcels, high power field, positive for urine positive for nitrites. Which of the following antibiotics is OR indicated for this patients as the first step? We have 5 answers: ciprofloxacin, cefalexin, norfloxacin, and levofloxacin.
You want me to give the answers? Is that the thing?
Yes, ma'am. Yes.
Yeah.
Yes.
Nitrofurantoin, yes. I have mentioned earlier also in my presentation. Nitrofurantoin, capelexin, and Norflox. This is lower UTI, previously healthy, and yes, dysuria. Yeah. We assume this is lower UTI, and you can start nitrofurantoin, capelexin, Norflox, one of those. Not Cipro, not Leo. Don't do.
Right. The second question: a 35-year-old male patient presented to the outpatient department with history of fever and cough for 2 days. He also complains frontal headache and myalgia. How would you manage this patient? A. Start oral amoxicillin and erythromycin immediately.
No.
B. Do a full blood count and CRP.
Yes.
C. No need to start antibiotics at the moment. D. Start the oral levofloxacin. E. Start oral aspirin.
Yes. Answers: do a full blood count and CRP and review. Then the number C, no need to start antibiotic at the moment. This picture most probably viral, so we can wait without antibiotic. We can review with the full blood count and CRP. If they suggestive of bacterial infection only, we can start antibiotic.
Right. Question number 3.
Start amoxicillin.
Diagnosed.
Yeah.
Yes. Next question. A 65-year-old diagnosed patient with type 2 diabetes mellitus with a history of chronic wound in lower limb complains of greenish discoloration on the wound. And there are no any signs of inflammation or any discharges. How would you manage this patient? Statement A: no need to start antibiotics. B. Start oral ciprofloxacin. C. Start oral linezolid. D. Ask patient to clean wound with rotation antiseptics. E. Patient should be admitted for intravenous antibiotics.
Right. This is probable colonizer, greenish, probably Pseudomonas colonizer. So, no need to start antibiotic. Ask patient to clean the wound with rotational antiseptic. Those are the answers. Those are the things should include in the management.
Question number 4. A 68-year-old previously healthy male patient presented to you with redness, swelling, and increased increasing pain on his right lower limb for 2 days. He complains 1 day history of fever. Examination reveals right lower limb swelling, undemarcated redness with tendons. His rest of the vital parameters are normal. What are the true false statement regarding his management? Statement A, oral moxifloxacin, oral cephalexin, oral cipraloxine, oral fluoxetine, oral linezolid.
Yes, this is cellulitis, patient not in sepsis. So oral capelexin and oral flucloxacillin are the drugs we can choose.
Question number 5. A 12-year-old boy presented to outpatient department with a watery diarrhea for 1 day. He has consumed street food from outside prior to the presentation. What is the management options? Start oral hydration solution. B, start oral progesterone. C, start oral cipraloxine. D, no need of antibiotics. E, stool culture is essential.
Start oral rehydration solution. No need of antibiotics. Those are the answers. Those are the true answers. Others are false.
Yeah, B and C, we don't have to start any antibiotics.
No, no. That is typical food poisoning.
Right. I want these 5 questions because it will enhance our audience knowledge, and it's very important. We have seen these cases, heavy practices in an outpatient department. You very irrational. This brings us to the end of the session. Actually, let me thank Dr. Deepika Priyanti, consultant microbiologist in Madara, who has contributed us with very short notice to our lecture, which is kind of very important in especially during this crisis era, because the wise use of antibiotic is very essential in our practice. And last but not the least, let me thank all the participants who's continuously supporting us throughout this period. Let me thank Sri Lankan College of Internal Medicine and its president and the coordinators who has organized this event for free knowledge academy. Let me hand over the session for wind up to Dr. Sahan. Sahan, session is over to you now. Thank you.
Thank you very much. So as said, for the behalf of the Society for Health Research and Innovation, I would want to thank Dr. Deepika Abeywarnaarachchi, the consultant clinical microbiologist from the Department of Microbiology from District General Hospital, Mathura. And also I want to express my gratitude to Dr. Himal Oshinde Kalambarachi, acting consultant physician from Base Hospital, Mahawar, for conducting the session. So as we all know that there are a few more questions left with us, and we will answer them, and we will send the questions to Madam, and we will answer them in due time. The last reminder of today is you can find the link in the chat box and kindly give your feedback as well as answer the post-assessment questions. Madam already has helped you on this, and you will receive the e-certificate for the participation. So we appreciate your joining with us today and hope to see you next weekend also. Thank you very much from Society for Health Research and Innovation. Have a very pleasant weekend. Thank you.